have to do a literature review and follow the literature, because there's a lot of changes which keep on happening in terms of the literature. And if we do not keep a track of that, there will be a problem. So why do we do a literature review? Of course, we want to change our practice. But before we change our practice, we need to know whether this article that we are really reading is worth changing our practice or not. So we need to understand about whether the article is valid in terms of whatever they have found is something which is close to the truth. The next, of course, issue will be that suppose this is valid and whether it is applicable to our setting or not. So if we have some intervention which is not possible at our level, so somebody tells you that you have teplizumab which is available, which can increase the latency of the diabetes by a few weeks, you would say, okay, but then the cost is prohibitive, it's not available, then it may not be generalizable to our population from that regards. Now, whether this represents a novel work and whether we should really change our practice or not. So we'll try to put these 3 papers on test and how they can change our practice and how they can improve or in that perspective. All of you can go and have a look at our website, learning.growsociety.in, which has got a lot of resources and courses related to pediatric endocrinology. We have got our fellowship course and a diploma course. We do run a number of grand rounds, postgraduate lecture series and journal clubs to highlight pediatric endocrinology. There are multiple publications which are available and the mobile application which really helps us guide in terms of evaluation. That if somebody has in vitro fertilization, whether that has an impact on the outcome of the child. Now, this study was very, very good, well-conducted study with a specific aim of the impact of high estrogen. So if you compare a IVF fertility versus a normal fertility, the major difference is they're doing a lot of stimulation to begin with. So the initial phase estrogen levels in the mothers may be very high. So what they're trying to say is that if your initial estradiol is very high, whether this results in a glucose metabolic dysfunction at 3, 6, and 10 years. So this was a follow-up study. And what they really compared was that these were the normal pregnancy, then the fresh embryo transfer and the frozen embryo transfer. So when you have a fresh transfer, you have a much higher ambient maternal estrogen because the stimulation is done there. For frozen transfer, they're just giving a 17 beta estradiol just to ensure that. So what they are finding is that children who were born to mothers who had a fresh transfer and also frozen compared to those who were normal had a higher fasting glucose, fasting insulin, HOMA-IR and HOMA-beta. Although the differences were within they don't look that much, but they were statistically significant. And of course, this means on a long run, these are younger children, their changes are occurring now, they may have an impact. So what they're really suggesting is that having a high estrogen around the time of conception may not be good for the metabolic. It programs the children. So this is a very interesting concept, how estrogen can program the child's outcome. And they in fact go ahead and to say that it is necessary to avoid exposing embryo to a high estrogen environment. And they are saying if your estrogen is very high, don't do a transfer. Store the eggs and embryos and do a later. So this is something they are trying to say that frozen ET may be better compared to a fresh ET. And when they are doing frozen, do not give too much estrogen. Try to do a natural cycle rather than an estrogen cycle. So what they're trying to say, which makes sense, that whenever you're talking about altering physiology, be careful. Don't overdo. Don't do too much estrogen. And that's why they are saying that high maternal estrogen in early pregnancy associated with risk later on. So this is something which is an interesting data, which is there. They wanted to explore later on in that perspective. The other thing which we talk always about, sleep and growth. We all know that growth hormone is produced at night time, the REM sleep and NREM sleep and all those parameters. This was a very elegant study in young children. So we're talking about 1.5 years. This is the duration at 1.5 years, and what has the impact at 3 years? This was a Japanese environmental study, and you can see they looked at so many other parameters in the sense of siblings, where they were there, tobacco smoking, nursery, and all those things. And if you look at the overall impact, if a child slept, and especially at night time, they were taller as compared to who did not sleep at night. And this did not include the daytime sleep. So what they really found out that sleeping is important, but nighttime sleeping is more important for these infants. And this is 1.5 years, very, very early study. So what they're saying is that importance of nighttime sleep duration, not total sleep duration. So when we say that you are sleeping for 8 hours, doesn't mean that it's good. It's the time of sleep which is also important. This was already a gender dichotomy. The females had a better benefit with that. Maybe they have a higher IGF-1 or whatever in terms of that. Male, they did not have an impact. But the overall message is that the nighttime sleep for children is very, very important as early as 1.5 years. So this is something because that's the time when the growth hormone starts to kick in terms of action. The third study was a very interesting study in which they wanted to look at mini puberty. What happens to reproductive hormones, the ovarian morphology, to uterine morphology in mini puberty, and how does mini puberty start and mini puberty end? So we know that whenever we have a child who is born, suddenly there is no inhibition which is there. And after that, the puberty starts up. And then the body realizes that, okay, now this is too early to have puberty, so it stops it. So I discussed this earlier also that humans are probably the only animals who have a childhood phase. Otherwise, they just have infancy and then they go into puberty and then they start to breed and other parameters. Now, why do we have this phase? Is basically because we want people to grow their mental development. There's so many intellectual development, and if we immediately burden them with fertility, that's going to be a difficulty. The second major hormonal adaptation which is there in humans is the menopause. Why do you think menopause is there? So why? So I said that you have a interruption of puberty after mini puberty. So mini puberty in a normal default mode would mean that, okay, you enter into puberty and then you go and have normal reproduction and everything. So that is taught because you don't want the humans to reproduce so early. You give them time to learn. If you are imposing a menopause in an older female, what advantage would that have on the human society? Just think about it. So suppose you have a young lady who has become a mother. Her mother is still pregnant. So then who is going to take care of the younger one? So this menopause is basically a way of nature of providing an additional somebody who can support the newborn. And this is important because human newborns are the most fragile overall. And that is why this concept of menopause also is something which is very, very significant from that. So coming back to the study, this looks very complicated, but what they're trying to say is that in mini puberty, you already have some concept of feedback inhibition happening. Now, why we are saying this is a problem is that because your inhibitory pathways are not there. But in mini puberty, when they correlated mainly the antral follicle count with the AMH level, with the LH level, with the FSH level, they did found that if you have more antral follicles, your FSH becomes less. So this feedback mechanism starts to mature. There's a very good correlation in those parameters. And then they give us very good reference range. So if you are now really looking at in terms of the ultrasound findings, you can go to this paper which gives you mean and SD in terms of what should be the uterine volume, the ovarian volume, the follicle count. So these are all parameters there. So this study has two important implications. One, they have given these reference ranges which were not easily available. And what they said is that negative feedback in the female hypothalamic gonadotropin is established during mini puberty. So before that, there is no feedback, but this feedback starts getting established at this point of time. This is what they have shown, and they have given cutoffs for all these parameters. So that's why this paper is relevant from that perspective. Now, this one is something which we already have discussed earlier about longer acting growth hormone preparation. This is somapacitan, which is a long acting growth hormone preparation from the Novo Nordisk. This is basically derived by altering the binding of this to a albumin site, increasing its half-life. This was the real 5 data, and this has now come up in JCEM. What they found was that they compared 0.16, 0.2, 0.24 milligram per kg per week to the conventional doses of growth hormone in the initial 1 year. And then they found that 0.24 was the right dose. And then they followed this up in the SGA children. And what they really found out was that there was a good effect in terms of the increase in growth velocity as well as the height standard deviation score. So what they're saying is that once weekly, 0.24 milligram per kg would be the ideal dose as far as sumapacitan is concerned. And hopefully, we are going to get the SGA approval soon. All of you can go through these articles, they are available, and that will be of help. You can go and have a look at our website, our courses to explore the publications, and our mobile applications in that regard. So, this has been important issues that we have been discussing about.